Welcome to What Makes Up Your Mind? Updates from the frontiers of neuroscience, well-being, and mental health from the Department of Psychiatry and Behavioral Sciences at Stanford University's School of Medicine. This is your invitation to meet the faculty dedicated to understanding our most complex organ, committed to curing mental illness, and inspired to help create a healthier, thriving world. Hello, I'm glad we're together again on What Makes Up Your Mind. I'm Jane McMillan. Every medical researcher and every care provider, they do what they do with one goal: healing. To keep developing the most advanced treatments and then to see them put into practice to restore health. So when barriers to that goal develop, scientists also take on finding ways to eliminate them. This is the work of Stanford Professor of Psychiatry, Dr. Shannon Wiltsey Stirman. Integral work to a special initiative of the chair, AI for Mental Health, incorporating the powerful tools of AI in forwarding mental health medicine. As co-director of Stanford's Center for Responsible and Effective AI Technology Enhancement for Treatments of PTSD, or CREATE for short, Dr. Wiltsey Stirman is developing and evaluating large language model tools to close the gap between research and practice, between new treatments and those who need them. And her years of work on PTSD treatments within the veteran community give her unique insight into the need for a game-changing tool like this. Now we continue our mini-series on Stanford Psychiatry's AI for Mental Health initiative with the work of Dr. Shannon Wiltsey Stirman. Dr. Wiltsey Stirman, thank you very much for joining us today on What Makes Up Your Mind. Very happy to have you.
Thanks for having me.
We're talking as part of a mini-series on the new initiative of the chair, which is AI for Mental Health, and your work is part of that. And your background, I know you have worked long and hard on the effects of trauma, PTSD. You've worked with the veteran community. Let's start just by talking a little bit about your focus in mental health.
Sure. I've been focusing a lot of my work on how to get effective treatments out there to the people who need them once we discover them. There are treatments for PTSD, for depression, for suicide prevention, for, all these different mental health problems that very few people end up with access to because there's a gap between research and practice, essentially. So if a new treatment gets developed, there's still a lot of work that needs to be done to make sure that the therapists, social workers, psychiatrists, the mental health providers actually know how to do them and that they're available for folks who need them. 30 or 40 years ago, PTSD was thought of as sort of a chronic condition that at most it could be managed and that people wouldn't really be able to recover from them. Since then, several treatments have been developed that have a good body of careful research evidence, representative of different populations, veteran populations, sexual assault survivors, natural disasters, car accidents, lots of different types of trauma that these treatments have been tested on, and they've been shown to be effective. But the therapist might not have been trained to do that treatment. So a lot of the work that I've been doing is around implementation science. How do we support, in our case, therapists and mental health agencies or mental health systems in making these treatments available so that we can keep kind of advancing both the science and the practice and helping make meaningful differences in people's lives?
So we can be clear on what we're discussing when we talk about trauma versus PTSD, because not all traumas result in PTSD.
Yeah, absolutely. There's been research to suggest that by adulthood, many, many, many people are going to be exposed to some sort of a trauma. And in fact, in the weeks after something big and traumatic, most people are going to experience some symptoms of PTSD. And then over time, a lot of people sort of have a recovery process where maybe they're not as hypervigilant, they're not as preoccupied with it. They're starting to feel better about it. They start to feel like they bounce back. And then for some folks, they don't quite bounce back. That can happen for lots of reasons. they don't really have the support, or if they are in an environment that's chaotic, maybe they don't really have time to process what happened, or if they experience something that is maybe ongoing for a long period of time, combat or long-term abuse, things like that, it will take some time to recover. PTSD is diagnosed after a month or two or three. People are finding that they have not experienced that typical process of recovery and bouncing back. Then we'll diagnose PTSD.
Do you think that a lot of us undersell whether or not we have been traumatized? Do you think that we, as a general population, recognize when we have been traumatized, when it is not something obvious like combat or a wildfire taking our home or a close call with death?
Mm-hmm. I think certainly there are times that people might minimize, especially if it's something that happened to a community, something like a wildfire. People might say, well, this happened to everybody. Other people seem to be able to move on, so I should be able to too. And then they don't really think about the impact that it's had. And avoidance is a symptom of PTSD that also maintains it. One of the ways we cope sometimes is, I don't want to think about something that was that upsetting. It was really awful. Let me put it behind me. Sometimes people don't fully want to acknowledge how much something might have affected them.
So the reason I ask that is to have folks be able to say, all right, so I see why I may be going in at some point to a therapist's office seeking help for anxiety or stress, and it may have been trauma related, now that you mentioned some of these things.
Mm-hmm.
So it could be more relatable. Oh gosh, if I were to do that, maybe, as Dr. Wiltsey Stirman is saying, I might not have access to the latest treatment. So where is that choke point? Where are the gaps? Is it the number of therapists? Is it the number of therapists who have access to the newest information? Where is that disconnect?
I think there are actually a lot of places there can be some barriers. Therapists very often have very full caseloads. So there's just a capacity issue. It can be hard to find someone who can see you on a regular basis at all, especially over the course of the pandemic. A lot more therapists having wait lists. There was already an issue. So there's just a general capacity issue for getting any kind of therapy. And then in addition, if you were trained 15 or 20 years ago, and now new research is coming out that there are new treatments, you have a choice of, okay, I can take time off to go to a workshop and then get trained and supervised in this treatment, but then I'm losing income because I'm not seeing patients when I'm doing that. In a healthcare system, they need to make sure that they're treating everybody who needs treatment. And usually those therapists experience some sort of expectation of how many people they'll see in a given week. Learning something new takes time, and it takes time away from serving the people that are right in front of you that need you. Sometimes there's also a knowledge gap, so people aren't even aware that some treatments are emerging, and so they might not be aware that there are new options available. Healthcare systems certainly face challenges in terms of getting folks trained, having the funds to support people going to new trainings, the support that's needed while people are getting up to speed on the new treatments. And so there are a lot of different reasons why these treatments might not be as widely adopted or used in clinical practice. And that's some of the work that implementation scientists have been trying to do over the years, is figure out what gets in the way, and then how do we address that so that we can make these treatments more accessible and make sure that the people who want them and can benefit from them can actually get them.
Well, then let's bring in this powerful tool, AI, machine learning, large language models. How do you see these helping in a system that is designed to deal with the most personal and deep issues of a human?
Yeah, so I would say there are different ways that artificial intelligence can certainly be helpful. Machine learning is a specific application of artificial intelligence that is very useful for things like detecting patterns, and usually takes actually a lot of data. Things like natural language processing can be used to review therapy session recordings and detect whether the effective practices are helping. And then there are these large language models, these newer things that we're all hearing about, things like ChatGPT, Gemini, the Copilot that you see on your computer. Those are all large language models. And there's been a lot of interest in using those, and actually even an earlier generation, to try to automate therapy procedures. So this would be kind of the chatbot therapist, is I think where people's mind goes first. For us, what we've really been thinking about is this ready for prime time? You could go to whatever chatbot, large language model you like to use and tell it that you experienced a trauma and say that you've been struggling. Um, there's been some research done on how it reacts and how it lines up with what a therapist would do. And what it does is actually pretty different from what a therapist would do. You might get kind of a sympathetic ear. It might make empathetic comments, and it might provide some suggestions. But it's not going to perform the level of assessment that a therapist would to make sure that, hey, does this person have PTSD? What else is going on? Is there depression, et cetera? The kinds of responses it's going to give are pretty constrained and really don't look like what a therapist would do. I worked with a team that actually made some comparisons, and other folks have done different studies to demonstrate that at this point, the kind of out of the box large language models that people have the most ready access to really don't do therapy. What we're seeing too are a lot of companies coming out with therapy chatbots. And we know that the technology is pretty amazing. And at the same time, there are things that it can't do that are really necessary for safe, private, effective therapy. And, until we see some of the technology of better, and until we see more studies to really demonstrate if this is safe and effective, I would say going right now to a chatbot for therapy, we just don't have great evidence that's going to work.
Could part of that also be because folks going there wouldn't necessarily know what they weren't getting, or wouldn't necessarily know what they should be getting in terms of feedback or therapy?
Yeah, I mean, I think that's part of it. I think, first of all, they interact, the large language models, especially if you just go to one that's a general one, it will interact differently than a therapist would. As I mentioned, it won't fully assess to make sure that it actually has a handle on what the clinical problem is. It certainly won't diagnose. I actually took a few of these different chatbots and sort of prompted them and asked them to give me basically a sample transcript of a high quality session of one of these trauma therapies. And I asked about a couple different trauma therapies. And if you just skimmed it and you didn't know the treatment well, it looks pretty plausible. It looks like the kinds of stuff that would happen, but it wasn't at all, it wasn't done in the right order. It was kind of a mishmash of things. And these more general chatbots, they're basically trained on all the language on the internet. There might be some books about therapy that are available that it's processed. But essentially, the way that they work is they're kind of predictive models. I mean, this is a very oversimplified way, but like when you do that word completion in Google for a search and you start searching and it finishes the sentence for you and gives
Sure.
you options.
Yeah.
That's a very simplified version of what these do. They look for groupings of words that go together that are more commonly associated with talking about trauma or trauma therapy. And so it can represent it that way, but it's not doing, well, first a therapist would do this, and then it would do this. And based on what this person said, they would do this. Because when I say that these models have been trained on all the language on the internet, it's things like Reddit subthreads and lots of web pages and Wikipedia. It's not been trained on data sets of therapy. If it had been trained on, hundreds of thousands of transcripts of therapy sessions, it might be able to do a better job. But of course, therapy sessions aren't available on the internet because they're private. And so it's really lacking the data that it would need to be able to approximate what we would see in a therapy session. And that's why they would have to be built specially to do this.
That leads us right to your work in particular. As we mentioned in the opening, you are the co-director of CREATE, the Center for Responsible and Effective AI Technology Enhancement, and this is of treatments for PTSD. So how are you looking at how AI can assist your work?
Yeah, so we're actually taking a few steps back. The technology really isn't ready to do direct to consumer therapy. It would take some training to do that. And there would need to be some advances in the technology, things like risk escalation and how much it remembers and the ability to case conceptualize. A therapist develops something of a mental model of what's going on with their client, and they decide what to do when in the session based on that. And these are things that large language models they're advancing rapidly, but they're not doing them right now out of the box. So what we've decided to do is look at how we could use AI and large language models in particular to support effective therapy and to support the dissemination or the spread of these therapies. So, using it for things like training and providing as needed consultation to therapists. So, we have two projects. One would provide a simulation. So, when a therapist is learning a new treatment, they can actually simulate the therapy with some mock patients that we've trained the models to look like typical and then maybe more challenging cases with different problems, different levels of complexity. And so the therapist can actually work with that simulated client, get real time feedback, and do things like try out, well, how do I take this treatment that works and there's a manual for it and I went to a workshop or something, but I need to do this in my own voice as a therapist, and I need to be able to feel confident in my ability to do it, and I need to know what to do if something unexpected happens in the session. So they can actually simulate those treatments and get real-time feedback, develop some confidence, build their skill and comfort, and then they can go and start providing it. Normally, the way we train people is, maybe they read a manual, they go to a workshop, or if they're in graduate school for psychology, they would be taking classes. Maybe they do some role plays with their supervisor or with other students. But then the first time they do therapy is with a real person sitting in the room. Then they would get supervision or consultation. And that's basically, they might record a session or they might just report back to their supervisor. Okay, so, today we had a session and this came up and this is how I handled it. I wasn't quite sure what to do about this. They get some input. And we have research showing that consultation process really improves clinical outcomes. But that's very hard to scale. You need people who can provide the consultation. Therapists have to take time out of their schedules. When somebody's first training for therapy, they should absolutely be meeting with a supervisor. But the simulation process gives people another way to learn and develop confidence without having to sort of try it out on a client, until they're confident and comfortable, until they're at a certain level of skill. Another project is providing on-demand consultation. So rather than, I had a case today, I'm going to see the person next week, but my consultation meeting is canceled this week, or I can't see my consultant for 3 more days, and this is on my mind now, they can just on demand work with a large language model that's been trained to have a lot of knowledge and guidance about what to do when you hit maybe unexpected things in a session or how to handle certain clinical issues. The third project is a project that actually works with different agencies and healthcare systems to use a large language model to support the development of an implementation plan. So we've got this new treatment or this new intervention or this web-based treatment or whatever kind of intervention we want to do. We've got to make sure that we can get it integrated into our system so that people actually use it and they can use it confidently and effectively, and we can triage the right people to get this treatment, et cetera. This project, we call it the Implementor, and it's a large language model that will support people developing a plan for implementation, guiding them through the plan, helping them troubleshoot. Maybe they check in every week and they give an update on, okay, well, I did this step, I've talked with our upper level leadership, they're in support of getting the training, and now we've got to figure out who's going to get trained. So they go through that process. They've got kind of a way to stay on track with the plan so that we're really supporting integrating these treatments into a system in a way that they can be sustained. And then the last project is a project where we actually will be having clients interact with a large language model through an app. Some of these treatments have practice between sessions. It might be a form, you're asked certain questions, you respond to them. It's supposed to help you through like a thinking process and develop kind of new ways of looking at what you're saying to yourself and making sure you're really looking at the whole picture and being fair with yourself, et cetera. And we're going to integrate the large language model into the app so people can get real-time guidance and feedback if they get stuck. Their therapist will be able to see what they've been doing between sessions and then kind of know when they come in, like, oh, okay, this is a place that they struggled, but they were able to get the guidance they needed, but here's a place where they really are feeling stuck, and maybe that's something we need to focus on today. So that'll be our direct to consumer, so to speak, but we'll still have a human therapist in the loop, because at this point, I think it's most appropriate in terms of safety and what we know about effectiveness to keep a human therapist very involved in these processes until we know a lot more and have really developed technologies that can be effective as a more autonomous therapy.
Mm-hmm. So human assist really is what you're talking about at this point.
Right, absolutely. Yeah. Sometimes when we talk about AI therapy, the analogy of a self-driving car can be helpful. So, it actually took quite a long time for autonomous self-driving cars to get on the road. And there were some setbacks. This is high stakes, right? You wouldn't just say, yeah, we're going to train a car to drive itself around, right? It took years of training data. And then for some period of time, there was actually a human in the driver's seat. First, the cars were recording data of how humans drove. And then they started becoming more autonomous, but there was still somebody sitting in the driver's seat to be able to take over if they needed to. That's kind of where we think we are right now, is we really need a human in the loop who's very involved, and either the AI is assisting them and supporting them, or when it is interacting directly with a patient, there's a human very much in the loop to make sure that the models are doing what they were designed to do in a way that's safe and effective.
That is a good analogy. And I think then it's fair to say that lots of folks are not convinced yet about self-driving cars either. Fascinated with the technology, but a little bit like, whoa, really? Do I want to do that without
Yeah.
somebody that can grab the wheel?
Yeah, absolutely. Well, I do think for some people, the anonymity of being able to talk about an experience where maybe they feel a lot of shame or embarrassment, which is
Mm,
sometimes something that people feel when they experience a trauma. For some people, I do think that they're open to the idea of sharing with a technology
mm-hmm.
that isn't a human, that, won't quote judge them or anything like that. Now, of course, we want therapy to be a place that feels non-judgmental. And for some people, I think having another human there bearing witness to what they experience can be a really important part of the process. So we do have a lot of questions about what will work and how effectively, but there have been some web-based trauma treatments and some self-guided exposure treatments for therapy that look like that make it look like this would be feasible. But I do think that there's something about that support that you get from a therapist, certainly the accountability, the human connection. And so I think these are great empirical questions. And that's another reason why we're not rushing to develop an autonomous
Mm-hmm.
therapist.
So when you were talking about the practice sessions, describing the homework in between sessions for a client, within your work, is that how you're going to be training the LLMs, the language in and the information in, or how is that going to be gathered?
One of the really nice things about large language models is you don't have to know. I mean, certainly there are engineers that have to understand programming. Just in terms of training it for what to do, it's nice because you can use plain language. So we can give it materials like a therapy manual. I think it's important to say we've got to be careful about copyright. You also need to be providing it with guidance around how to address certain issues that might come up clinically, about the tone, about the way to respond, telling it what not to do. If there are other therapeutic techniques that the large language model has been exposed to on the internet, you might have to constrain it and say, don't do these things because they actually run counter to the way this treatment works. You might give it some examples of good responses to certain things. This is how you might respond if someone were to indicate that they were confused about this, or this is how you might respond if someone said that they didn't know where they should start working on trauma. You provide it with guidance, you provide it with examples, you provide it with materials that have the foundational information. After that, it's kind of a series of different things you can do to refine it. You get user input and feedback, you get expert feedback. And through that process, kind of iterating, you get it to a point where it's performing and doing what you would expect it to do, responding the ways that therapists would. You need to do a lot of testing to make sure that the responses are safe. I mean, we were all hearing about large language models hallucinating. We want to make sure things like that don't happen. The approach that's being used right now is actually more of a multi-agent model. So you might have one large language model chatbot that interacts directly with the client. And then there'd be another one that was in the background, kind of evaluating how that model was responding and giving it guidance. You might have one that's specifically for risk detection. So if the person starts talking about feeling suicidal, it would be alerting and working with these other models to determine, okay, do we need to stop and address the suicide, or continue with what we're doing therapeutically so that maybe the person will get some relief from the suicidal thinking and feeling through the therapy. There are all these different layers that are used to make sure that what needs to happen is happening in the session.
Within your research and the safety of that, are there any live sessions that are recorded and fed into, anonymously, of course, but into the LLMs to help train them?
No, we don't use full sessions for this. Earlier versions of training natural language processing did rely on a large body of anonymous therapy transcripts that were labeled by experts who could say, this is this technique and this is this technique. That's how those models were trained. Large language models don't use therapy transcripts. What we would do instead is give a few examples of Socratic dialogue, which is a process we use in some of the trauma therapies and some of the cognitive behavioral therapies to help someone tap into their inner knowledge and their memory of what happened and come to know things that maybe they haven't fully let themselves face because they've been avoiding the trauma memory. So this is an example of the types of questions you would ask in Socratic dialogue if someone said, oh, it was all my fault that this happened. Examples could be real anonymized quotes, or more often it's just sort of here's a prototypical type thing that you could say, or here's the type of thing a therapist would say.
I see. What you're describing, the work that you're doing at Stanford, and you have many incredible partners in the center, Create. Obviously, that's going to be of the highest evidence-based, vetted information. But there's money to be made in some of this, a lot of this. And in the beginning, we were talking about DIY models out there now that somebody could look up on the internet and do an interactive session with. For consumers who don't have a therapist, but are just going on their own, are we going to get to a point where we need to see the credentials of who fed information into these AI self-help outlets?
Yeah, I think that's a great question. I do think it's really important when we're developing these more specialized models that there be really, really close involvement with people who have clinical expertise, who know these interventions well, who know depression or PTSD or anxiety well, so that they can really be providing close guidance on how these treatments work. We talk in the psychotherapy research area about tapping into mechanisms of change, which basically means if something's working in a therapy, we want to understand why. How is it working? Because when we know how it's working, then we can actually be more intentional about making sure we're doing more of that or doing it at the right times. One of the things that we're doing in our work is really looking at making sure that we're tapping into the things that are going to promote the change process and measuring to see if we're actually doing that, if we're actually activating the different change processes in our work. And that's something that I think industry, as they're developing these things, without the clinical expertise, they're probably not going to be doing that. They're going to be training things to kind of approximate therapy based on these foundational models, which are trained on the whole internet, and then maybe saying specifically, do the things that they talk about doing in such and such a manual. But it won't have the more clinically sophisticated approach that you need. Now, could we get there one day? Quite possibly. These models are evolving fast. I just want to make sure we don't get ahead of our skis with it, that they're safe, they're private, they're effective, and that they are trained by people who really do have the knowledge base.
So when you're talking about reviewing and making sure everything is safe and effective, what steps are you talking about? What are you looking for in a treatment-supported environment?
There were a few different domains. We put forth a model of the different things that you really need to pay attention to when you're evaluating these. That the large language models will respond safely and appropriately detect and handle risk. Privacy, we want to make sure that there aren't data leaks. This is really sensitive information. Anytime you're evaluating one of these models, just making sure you understand where it's stored, what the terms of service are, always evaluating for privacy. Our stuff is going to be in a very secure environment. We need these things to be ready for implementation, to be safe and integrate with healthcare systems when they need to. The effectiveness, and this isn't just we tried it with 10 people and they felt better. Like this should be compared to other treatments or other interventions and seeing that it's at least as effective as the best ones. We want to make sure that they feel like a good fit for the broad population, that the ones that we are using with clients, whether somebody's experienced a combat trauma or a sexual trauma or a car accident, whether they live in a rural or an urban place, that they will feel like the chatbot is responding appropriately to them. And we need to make sure that the level of engagement is right, that people engage enough so that they're getting an effective dose of the intervention, whether it's a therapist getting training. We don't want them to try it once or twice and then stop, just like we wouldn't want a client to stop using it once or twice before they've really gotten an effective dose. But also, we don't want people to be dependent on them, so assessing and evaluating that we're at the right level of engagement.
That is reflected in the name of your center, the Center for Responsible and Effective AI Technology Enhancement of Treatments for PTSD, or CREATE. Dr. Shannon Wiltsey Stirman, thanks so much for explaining this to us. Very exciting.
Thank you. It was really nice to talk with you.
Dr. Shannon Wiltsey Stirman, professor of psychiatry in the Stanford Department of Psychiatry and Behavioral Sciences, and co-director of CREATE, the Center for Responsible and Effective AI Technology Enhancement of Treatments for PTSD, and also co-leader of Stanford's Tech Hub, the Mental Health Technology and Innovation Hub. The work of CREATE, developing and testing these AI human assist tools, will happen over 5 years or so, with special attention given to their safety, privacy, and efficacy. We've got links and much more information. Check our program notes, and please do listen to the other podcasts in our AI for Mental Health mini-series on what makes up your mind. I'm Jane McMillan. You've been listening to What Makes Up Your Mind? Updates from the frontiers of neuroscience, well-being, and mental health from the experts in the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine. For more information on this program and all of our transformational work, visit us at med.stanford.edu/psychiatry. What Makes Up Your Mind? Updates from the frontiers of neuroscience, well-being, and mental health is a production of the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine, a copyright of the Board of Trustees of Stanford University.